No.
Good evening, Nolan.
You're very
Thank
welcome.
you.
Yeah, anytime.
Don't understand, it's not. This is on, but it won't connect to me as the host. So confused. There we go. It's just delayed.
Meeting is being recorded.
Sorry,
Yes.
I have to take off for various reasons. I'm really sorry.
Thanks, Brad. Okay, thank you, Brad.
Yeah.
So we're opening up the meeting at 6:03. We're a little late. Sorry if any of you are on Zoom. And now we are time for public comments.
Good evening, Linda White, community member, and Brad, before you sneak out the door, I just want to acknowledge the voice of Brad on the board, being a champion for peers,
I'm sorry.
and if you have to go, that's okay.
No.
I want to
didn't realize-
compliment
I didn't
you.
understand what was going on.
Particularly in your Save Pine Tree Gardens work and your voice to make that happen, always being present for that issue. And it was extremely appreciated, and having your voice on this board has been invaluable to me, and I appreciate it so much. Chris, having you as a champion for diversion, neighborhood courts, all the various diversion programs, I still have pangs in my heart from our presentations to the community on Hold It On. That made a really strong impact on me. And so I appreciate your voice, not only in defending the mental health clients in the judicial system in getting their rights and their capabilities for recovery recognized, but also your output to the community, and all that you did for letting the community know that there's more than one way, like the ticket to jail, for solving issues in the community. Carlene, I'm sorry I didn't get to know you all that well. I was kind of on a first name basis with Karen Larson, but I have come to respect the reins that you pull in. I was one of the people that was foaming at the mouth for Crisis Now because I believe strongly in my heart that that's the way we need to go, but it needs to be done judiciously, fiscally, and make it a success. And so I appreciate that part of your role and what you did also. And also, our family has benefited greatly from conservatorship and pulling the reins in a little to implement the expansion of the gravely disabled definition was important, because there again, we want to get it right. And so I appreciate you, I wish you well.
Thank you.
And I was kind of having some family personal issues with my husband fighting cancer. So you haven't seen me at all the local mental health board meetings lately, but that doesn't mean my passion has dwindled. If anything, it's even stronger than before for the issue of reaching people before they hit rock bottom and diverting them when it's appropriate, and having a voice that knows the history, knows what it feels like, and can put that in touch with people that don't know. So thank you.
I didn't mean to interrupt you. I'm sorry. I didn't understand what was going on.
Appreciate you so much.
Yeah, and I'm really glad about Pine Tree Gardens too. I forgot about that for a little bit, but, Bill Williams was like my grandparents, to be totally honest. And Pine Tree Gardens was a godsend. And funny enough, just a couple days ago, I saw Kathy Williams, and she said something about, so sorry, I don't know much about business deals, because didn't really make much in my lifetime. But, that, like, things have been settled with the county, so that Pine Tree Gardens West, like, it's off of her hands and completely into the county's hands right now. And Kathy Williams was very happy about it. And, I would say something, I would say, anytime any of you guys get a chance to thank Kathy Williams, I would. I mean, do you know what she told me? She wasn't even talking about all the money that she gave up. She was talking about her brothers that she loved so dearly that suffered from a mental illness too. So, the Williams families were it's Kathy Abbott, all wonderful, and I would, anytime you see Kathy, I would thank her.
Thank you so much.
Thank you,
Thanks, Brad.
All right, you guys will see me again.
Remember, Ed, take care. Any other public comment? Is there anyone online? Any public comment from anyone attending virtually?
I'll go ahead and just say a few words. I don't know how to sum it up into words, but can you hear me okay in the room?
Yes.
Okay, good. I already kind of said my goodbye to Chris at his graduation from mental health court. So I'm just excited to see, you know, what the chapter looks like for you, Chris, in the next chapter, and your work here continued. Carlene, I don't, you know, I know that you're going to go out and champion, you know, in some other way, in another capacity. And I'm excited to see what that looks like. And I've enjoyed learning from you and being guided by you. And, you know, it was a rocky journey for me, you know, the last couple of years, but kudos to you for having the grace and the insight to just handle family members like me and our loved ones, and work with us and come together and show us ways that we can partner and grow and do what we really want to do, which is make things better. So thank you for just your patience and all the grace that you have shown me.
Thank you so much, Christy.
Thank you, Christy. Okay, so, and then if anyone wants to say anything in member announcements, any members, you can when we get there. So let's move to the approval of the agenda. Can I have a motion to approve the agenda? So moved.
Second.
Chris first, Maria second. All in favor?
Aye.
Any opposed? Okay, motion passes unanimously. Approval of the minutes from our December meeting. I'll entertain a motion to approve the minutes. So moved. Chris moves, second from Maria. All in favor?
Aye.
Opposed? Abstentions? None? All right. And chair report. The main thing I want to say is it's time to find new officers. And I know last year I told all of you that if you wanted to be the chair, that don't let me get in your way, because I was ready to move on. And we worked it out that I would do one more year, which is now upon us. So we're going to be looking for new officers, and Maria has graciously agreed to sort of chair or lead an ad hoc, which I'm going to appoint to recommend at the next meeting slate of officers. I'm certainly planning on being involved, you know, with as much as you want me involved, and sort of, you know, with the institutional knowledge. Maria has a lot of institutional knowledge also. But I would hope that a number of you would be interested in some of the positions. And if you are, you know, you can reach out to Maria. But I'd also like to have two other members be on this ad hoc. And probably individuals that maybe aren't interested in serving as officers, to kind of recruit and come up with our slate as we move forward. So who would like to do that? Who doesn't want to, isn't necessarily interested in being an officer? Nikki's like, I don't want to be an officer.
You did her time, you
So
know?
Nikki is one, and can I get one more person?
Someone could be voluntold.
Yeah, it's not a big lift.
Maybe everyone wants to be officers, that's why
Yeah,
they're
maybe
not.
not.
Okay, I think Maria and Nikki.
No, not the officer, but the.
Yeah, I know what you mean.
Yeah.
Yeah,
The nominating committee.
Yeah.
I think Maria and okay.
Could you talk about the chair responsibilities so that people know, like, or any of the positions really, so that people know what they might be getting themselves into?
Carly, see what it's like, now you get to be put on the spot. She would be like, yeah, now you know what it's like. Yeah, gosh, I wasn't prepared for that. Working with, the other officers, trying to connect and work with other board members. I know I've spoken to a lot of you, individually to find out, how you want it, how you think things are going, how you think we can improve things, running the meetings, helping formulate the agenda, obviously working with our mental health director, sometimes, interfacing with Nolan and the other people that are involved, like in the past, like Tony. I mean, for me, everyone's gonna, those are the main responsibilities, trying to keep on track and getting the tasks we need to get done, which I feel, that's one area where I feel I could have done better at in terms of the different things we're supposed to be doing. And as a board, that's something that I think we could do a little better on moving forward. So that's kind of on me a little bit. For me also, trying to, and I don't know if this is really a chair responsibility, and this is something I would hope we also be doing moving forward is, kind of working behind the scenes and talking to people and working with, whether it's other department, so much of it is about relationships, other department heads, whether it's NAMI, that's an important partner. We have UCD NAMI here, that's now going to be part of the team, and we'll talk about that in a bit. Whether it's, answering questions or talking to members of board supervisors or their deputies. Am I missing anything?
Jonathan, do you want me to read what's in the bylaws? Because there is something in there. Do you want me to read
Yeah.
what's in there? So the chair shall be the principal board officer, shall chair the board meetings and serve as the board's chief spokesperson. They shall carry out the policies of the board and shall do everything necessary to carry into effect the board's statutory responsibilities and additional board goals. The vice chair shall do everything necessary to assist the chair in the performance of their duties. In the event of the absence of the chair, the vice chair shall exercise all powers of chair. The secretary shall review the minutes of the behavioral health board prior to distribution, assist the chair and vice chair in the performance of their duties. And in terms of formal meetings, there's agenda setting meetings with Christina, right, to work on developing the agenda for the upcoming meetings.
Yeah, so about a week out from our meeting, we meet and discuss the agenda. Christina sends us a draft agenda. We get the mental health director's report. And then we need to get that out, within the 72 hours for the Brown Act. So that's usually on Friday before a Monday meeting. Nikki probably knows exactly what needs to be done.
Well,
Sure.
I don't know that I know exactly, but one of the other things that's not in the bylaws is that the chair is supposed to review the applications and or resume of people that supervisors are considering appointing to the board. They're supposed to run that by you and get your.
Yeah, and that's a hit and miss. And
It's hit and miss, but the supervisors are only gonna do it if you,
yeah,
give them a friendly heads up.
yeah.
That A, they have an opening, and B, when they're thinking about appointing somebody, you'd appreciate getting a copy of their application.
Yeah, and we do.
resume.
I actually do get the copies.
But generally, that's supposed to be before. And the reason it's supposed to be before is because you can pick up either really good things about the person, why they would add something and bring it straight to the board, or perhaps a potential red flag. They work for a company that has a history of contracting with Yolo County. It's another pair of eyes from the perspective specifically of the local mental health board. the board doesn't always have that top of mind when they're making those appointments.
Yeah, and what I would say is we do, when those resumes, applications come in, the board clerk sends them to us, to me. And I guess what I was trying to say more is, some board members are more receptive to input and feedback than others. So that's just the nature of the beast.
I used to find that, that they were much more, willing to do it when they knew that I was also going to tell them what the pluses were. I mean, what the advantages of this member might be.
Right.
So it's kind of like, okay, this makes me make that decision, or maybe I ought to think about this a little bit more. It's like you said, relationships are everything. It's how it gets couched, not coached.
And the other thing that's statutory is this board is supposed to be involved in the selection of the mental health director.
Yes.
And I was really pleased because I was, trying to whisper in Nolan's ear and some others, and they were already kind of on that.
We'll talk about it.
Yeah, so they're gonna talk about that a little bit later, so I appreciate the fact
There's some
that-
other welfare institutions, good stuff that is applied as well. Signing authority and some other bits and pieces for the chair.
Yeah, okay. All right, so let's, I think I actually skipped, did I skip member announcements? I think I skipped it, yeah, sorry about that. So let's go back to member announcements. Any member announcements?
Just a few things.
Okay.
So one, I did contact Jonathan last week to let him know that with my job responsibilities, I was not going to seek the board's endorsement for an officer position. So that's why Nikki and I are working together because I will not be in that running. So, I really want to encourage people to think about it and to participate. It is worthwhile.
It is.
You're working with a great group of people, and, Carlene was great, and Christine was wonderful, and Tony's always been great, so I would really encourage you to step up and try to participate. Carlene, I also wanted to thank you. I know you did walk into fire. I remember that meeting. I'll never forget it. But with patience, and you just listened to everyone, and you really heard people and responded and were thoughtful in your responses. And to Jonathan's point, you really tried to give what you could and explain when it wasn't going to be available to it and for the reasons why. And that was really important, I think, in the time that we were in, to really help smooth those relationships and build this board and build kind of the connection. So I really do want to thank you for that. And Chris, you kind of carried the torch after Jonathan left the DA's office to really continue to connect the board to how important those meetings were in the courts and asking for participation and trying to get the virtual options available for us to participate. And I think that does make a difference. The more people understand, the more they can advocate and really have a voice in this process. So I wanted to thank you for that. And Brad, I know he's not here, but he has been on the board before me. And I always remember thinking, what a wonderful voice he lent to this process. Things that, maybe I had seen in my personal experience with my family, but really to have it voiced in such a considerate and thoughtful way, and always from a perspective, not just self-serving, but really thinking about others. And I really appreciate his participation. So, that's my memory.
Thanks, Maria. Anyone else? All right, any correspondence, Christina?
Just Carlene's resignation.
Okay.
Rejected.
He did come around, I do not accept.
All right, so we're right on schedule. I'm very, very excited today to hear from Nithya Gamti from UC Davis. I think I reached out to Nithya, I actually think I reached out to Jen and said, who do I talk to connect to, UC Davis? And she said, Nithya. And that all started, I think, partly because in one of these meetings, one of us was talking about, a little bit of a disconnect between UC Davis and the city of Davis or the county of Yolo. I also had some conversations, someone that I know at UC Davis put me in touch with some of the higher level managers that deal with the mental health issues, and I had a meeting with them, which I thought went really well. And we'll have a follow-up, and I asked them to come maybe talk to us also. And I think it was Kim that was the one that said that kind of lit a fire under me. So since the last meeting, I reached out to Nithya. We Zoomed for quite a while. I was really impressed with her and what they're doing. And I asked if she would be willing to give us a report on what's going on at UC Davis, in the world or space of mental health, and also with NAMI at UC Davis. And she agreed to come, and she wanted to come in person, which I thought was great, even though I gave her the option of Zoom. And so here she is. So Nithya, do you want to come up to the front, or whatever you're comfortable doing, or do you want to, or you could have a seat. Why don't you could have a seat also if you want, or stand, whatever you want.
Yeah, don't mind. I'll stand. Hi everyone, I'm Nithya. Thank you for that great introduction. I am a student at UC Davis. I'm currently studying neurobiology. My full major is neurobiology, physiology, and behavior, but I usually just say neurobio because otherwise people think I'm triple majoring, and that's quite a lot. I am also minoring in professional writing, so I like science, I like the arts, and I'm super excited to be here. I've been in the NAMI UC Davis since my freshman year, so this is my 4th year now. And I will be graduating soon, but I'll be making sure to bring someone on also who will be interested, who will be continuing, so that won't be a problem. But otherwise, I guess I can get started about what we do on campus. So specifically, we are focused on the campus community, although we do like to reach out a little and try to help more, like 18 to 25-year-olds is our main target group, just because we can relate best to them. We have worked in the past a lot with NAMI YOLO, so we've had a lot of fun at NAMI YOLO walks, and we've brought some guest speakers on. So we've been trying to get a little bit more involved in the greater community other than just Davis. But otherwise, for this quarter, school did just start this week, so we're just starting up. We had our first NAMI UC Davis board meeting yesterday, so this is perfect timing actually. For the quarter, we have weekly meetings, so we try to alternate between informational meetings, so people who want to learn more and get more involved can come to those. And we also try to do like more fun meetings that's like de-stressing because we're all students, we all understand what it's like to be a student, especially since midterms are pretty much every other week on the quarter system. So as for some of the informational meetings, we have some really cool meetings. We haven't really 100% thought them out fully, but they're in the process of being prepared. One of them was about seasonal affective disorder. We just kind of want to spread awareness about that, especially since it is the winter time and it can be very common. Another one is just kind of about relationships with friends, family, significant others, how to recognize red flags, toxic relationships, stuff like that as Valentine's Day comes around. So we do try to keep it very on theme with the season, the holidays that are coming up, to try and keep students more engaged. But otherwise, for fun meetings, we have cookie decorating for Valentine's Day. And we also do want to make cards for loved ones that we know, but also to give out to local hospitals, just to kind of spread the love. I think everyone can use a little extra every now and then. But otherwise, we are always open to guest speakers or any sort of training opportunities. If anyone would like to come talk for us, I would love to get in touch with you. And then also we are very, very excited to and always ready to volunteer or to get more involved in the community. So if there are any opportunities, we would love to be a part of it. Thank you.
Any questions?
How big is the chapter?
So our chapter is around 25 students. And I say around because we don't have mandatory attendance.
Right.
Again, we totally understand that it can be busy being a student and also being involved in other things.
But
So-
you have enough to get resources from ASUCD.
Yes.
That was what
I think so, yeah.
You only need 7.
Oh, okay, perfect. Yeah, so with ASUCD, we aren't technically a school-funded organization. So we are a registered organization as part of the university, but they have their own mental health called Aggie Mental Health. So that is a little different, but that is someone that we've also worked with. So that's someone that I can reach out to on behalf of the local mental health board. I can totally do that as well.
But you know, if you wanted to come up with a few activities for the beginning of the year, at the beginning of the year, when everybody else is turning theirs in, you have enough members that you could probably get several activities funded. That's really, that's the point I was trying to make.
Yes, we do.
Take advantage of ASUCD.
Yes, so yeah.
Hi, I'm Kimberly. I think I may have met you a couple
I think
months.
we've met.
Yeah, from just kind of visiting campus NAMI to try to like connect. But yeah, anyway, so from my understanding of your organization, you're primarily kind of more a professional and volunteering organization.
I've been,
Yeah.
sorry, go ahead.
Rather than, so NAMI as an organization in each county, it tends to be a lot of either family members or people that live with mental illness themselves. But versus like kind of from what I understand of like campus NAMI, it seems to be more like a professional or volunteering organization. Would you say that's accurate?
So I wouldn't classify ourselves as professional necessarily, but I would say it is, we try to give volunteering opportunities and training opportunities, but a lot of our members are people with lived experience. So lived experience are people who know people who have been living with a mental illness. So I would say not necessarily professional, we try to keep it very casual, make it a very safe space for students, but it is like a volunteering and just kind of a get to know other people who can relate and people you can talk to. So maybe community-based.
Okay. Yeah, and I just want to say, like, I'm really glad you're able to come here and present it because I've been talking about for a long time about how there seems to be a disconnect between county and then the university, and then as a population of like what I think it's 40,000 now in this county, it's like the student population is fairly significant, so it's good to kind of hear this perspective.
Thank you for vouching for us.
Yeah, because I'm alumni of UC Davis, so I went there, I graduated in 2020, and I have lived experience of mental health issues that I lived with while I was there. And kind of what I found is there's a lot of campus resources and community resources available, but the issue is students don't necessarily know what to go to and they're not connected to that. And also there's a lot of concern with lack of training towards mental health on campus, both in faculty attitudes, student attitudes, and I think especially in terms of emergency response to mental health on campus. So that's something I kind of really want to look into. Yeah.
And that actually does remind me, we started a project of our own. We're trying to make a huge resource book for students, but not necessarily only resources on campus. But essentially our idea is it'll be like a digital resource book. We want to include information about different resources, like the name, where you can find them, how you can get in contact with them, but especially is it free or not, or how much you have to pay if you do have to pay, and what exactly they do. And hopefully we want to spread this around campus. We want to make it easily accessible. So we're working on revamping our website, trying to get it up there. So we have a lot planned for this quarter of this year. So we're super excited.
What is soon?
Oh, I just want to know, are you mostly focused on undergrads or do you work with the professional graduate students too?
We don't have a requirement that they have to be undergraduate to be a part of NAMI at UC Davis, but most of the people in our organization are undergraduates. We have nothing against professional grad students. We just don't know that many that are interested in coming to our undergrad meetings.
Oh, okay. So you don't do outreach then to the,
We
we have law
haven't-
school as well. I'm not
Okay.
saying.
No, we haven't yet, but we are totally open to it. We've had a couple people from the law school actually. It was last quarter when they were a part of our club. And so, or I guess at this point it was spring quarter, sorry. I keep forgetting we're in winter quarter now. So it was spring quarter and we had a few law students and they were really cool. We'd love to, we just we haven't reached out, we haven't made that connection.
Nikki?
I was just you said something about seasonal affective disorder. And what I remember is that when I first came up here, I didn't know what it was because I had lived in Southern California where there's generally sunshine. And my first winter up here, was just very, very difficult for me. And I didn't find out what was wrong with me until the sun came back. So I'm just saying, there are people who may not identify that that's what they have, but they do. Seasonal affective depression can really affect people, particularly if they've come from somewhere where it's generally sunny.
Actually, it's really interesting that you say that because someone close to me recently, she had no idea that she possibly had seasonal affective disorder, but she had noticed that like during the winter she would feel down and then during the summer she'd feel a lot better. And so they make lamps where you
Yeah,
can
they
like
do.
plug them in, and she got one, and she's actually my roommate. So now we have this giant lamp in our room, and it's actually been wonderful too.
Is it
That's
made
great.
for, is it just a lamp or is it made for
It's-
supposedly?
It has a
Special-
UV light.
special-
Yeah, a special spectrum that's supposed to
See,
sunlight.
my wife feeds me vitamin D because I'm Southern Cal too.
It's a real thing. I remember I had to sit underneath dim lights for a while too, because of the constant overcast and blocking of the sun. So, no one would have thought that something like that was going on, but it's real.
Not really a question, more of a comment. I think in the county, to your comment, we really struggle to make any connections that UC gave us on a regular basis. By the time we find a good connection there, they move on somewhere else or we move on. So, the university is also developing sort of its own crisis system of care while the county is developing theirs. And there's not a lot of coordination and synchronicity there. And I guess where I'm getting to is like any chance the county has the opportunity to work with inspiring young people like yourself, we're going to jump at it. We've got opportunities for peer support workers, obviously maybe convincing folks to get a job in the county when they graduate or look into mental health services, right? We're always looking for clinicians and things of that sort. So if there's any way we can connect after this meeting, we'd be happy to host a meeting in our wellness center for you guys, or maybe this body can have a joint meeting on campus with your group. But I think anywhere you can connect things like that and build those community resources, the better. Jonathan assisted in setting up a connection with the new government affairs officer at UC Davis. And so we're starting to make those connections again, but it is so hard for the county to work with the university. And we're both probably at fault, but we'd love to connect afterwards. So if you've got contact information or something, I think, the more, especially we can work with people at the ground level that, can bring that live voice experience is so powerful. So please, before you leave, give me an email or a phone number, because I'd love to connect with you.
I would love to. Thank you.
And I like that idea of a joint meeting.
Yeah, that'd be super cool. And we can totally host it on campus,
Okay.
If that's okay. I think it's a little difficult for some students to come out here. But
Yeah.
thank you.
Yeah, I really liked your earlier idea of kind of building a resource book for students, because again, there are resources available, people just don't know about them. And you best believe, like, if I knew that the Global Mental Health Board existed when I was like 18 years old, going to UCD, I would have been here for sure. But I just was not aware this existed at all until I got involved with Mami YOLO a couple of years ago. So like, there are people that have an interest, there are people with lived experience, there are people that need support. But the thing is, they're not necessarily getting connected to help or getting connected to community that can support them. So I hope like we can all kind of try to bridge the gap with that.
Well, and I hate to keep adding ideas here, but I mean, so we run 211 services in the county, right? It's a county operated service. You call 211 from your phone right now, you'll get our resource and referral line. They produce a senior resource guide every year in the paper. So they take all of the senior resources that come out of the county, they package it, make it look nice and pretty. We could easily run a mental health services, sort of, unfortunately, there's not tons of resources, but they could do some of the legwork for you, work with you, could be a partnership. Maybe the local mental health board could help author it. Maybe you could actually provide your lived experience to make something that a young person would pick up on campus and not just toss in the trash and say, hey, this looks helpful. I mean, we could cross-pollinate all those areas. And again, it's like the county, we move slow, we're kind of old school and archaic and bureaucratic, but when we have the power of young people that have a vision and other folks like yourself that are on these boards, we can develop some really cool stuff. So that could be a really cool project to kind of cross-pollinate on as well. Yeah.
So if we could tag on to that, as I think a lot of, there's another gap. So there's resource gaps everywhere from, cradle to later on. And so if there's a way to put that all together, and maybe there's not Jen to put you on the spot, but maybe there's a way for NAMI to kind of help us with that, knowing that you're doing it, because everybody's kind of wanting the same thing, but in their own silo.
Yep.
So I love how you're thinking if we could maybe bridge that gap and put this
Great
resource
suggestion.
out. Yeah. And then
like a
it's-
211 is also our asset, so
Exactly.
we can easily connect to this group. And sometimes the county is not, and again, that lived experience of folks that have gone through trying to find that resource or
Right.
struggling, if I knew this, like, we just don't see that a lot. And that's, again, why we have boards like this, but we're more than happy to bring in those resources. And they're limited, but the more you can tailor them and make them user defined, the better, so.
We might
Great
consider,
suggestion.
consider making it 3-in-1 and have K through 12 added in there too for parents.
Yeah, well, I mean, even if we were to connect with all the great resources in NAMI with the classes, right? So when we do the peer-to-peer support group, it's the same questions running through all the time. It's the same ones.
Yeah.
It's, what changes is it an adolescent?
Yeah.
Is it an elderly person? Is it, is it a student? And so I think if we could put that together, because I'm thinking you guys hear the same thing when you have your classes. And so even then, we can also bridge where the classes you could go, because as soon as these folks get information, then they have power to actually understand some of the resources even better.
Or even starting earlier, like, so you have a diagnosis, right? Or like, so you think you might need to go to the doctor for this problem.
Yeah.
Step one all the way, it could be a really powerful tool.
Yeah, and then John, K through 12. So I think there's a lot of really cool things, and not that you're signing work, but that would be really cool. I think that's kind of thing.
Anyone else? All right, thank you.
Thank
Nikia.
you.
Hope to see you regularly. Appreciate it. Okay, so up to our mental health director. Are there items that people want to pull?
I would, and I'm not asking the boy, need someone to do that, but I would like to speak on the leadership transition. I know if someone wants to pull that.
Okay,
I have a
leadership,
question about that.
what was that?
I have a question about that. I didn't understand.
Where, oh, that's B? Okay,
I want to pull D,
D,
care act implementation.
okay. What else? One of the things I was happy to see here, I'm not going to pull it, but is the report from Dr. Jetta on what's going on in the psychiatry and things. That was a nice addition.
Jonathan Cleos.
Yeah,
There's
you can pull
some-
that.
You want to pull that?
I just have a question.
Okay.
Yeah.
Which one is, what?
Yeah.
It's F, okay. And,
Do we need to pull E also?
yes, yes, we do. D,
yeah.
What are you, were you asking?
Sorry, well,
The question you had, D?
I want to
should we just go through each of
The
them?
whole thing?
It sounds like,
I
there's only,
don't think we have all of them.
there's only,
There's only 6 items.
Yeah, yeah. Okay, so we'll start with
there's 6.
I wanted to see
C.
D.
I'm sorry,
Who can petition
which
the board
ones?
and the community?
Which ones do you want?
It's about the CARE Act.
Yeah,
I think we already have it.
implementation,
Yeah.
yeah, but specifically more because I was reading, who can, in the community
Okay.
can,
We'll get to the question in a minute,
okay.
John. Okay, so no one pulled A. Is that something you want to talk about?
Yeah, I think we would like to talk about it, if that's okay.
Yeah.
So, we are currently working on the draft request for proposal for the Crisis Now, Crisis Receiving Center, the Behavioral Health Crisis Receiving Center. So, as you all know, that is the critical missing component, to our crisis continuum. The construction process we're getting to the point where construction will start soon. And concurrently, we are working on the RFP for the operations of the facility. And so we would love if there was a member of the local mental health board who would be willing to be on the panel for the RFP review. In terms of timing, there is some time. We're anticipating that this will be released probably in February. And so then the review of the RFP would probably be happening, I'm guessing, in April. March, April, depending on how long it's open for. So there's still several months until you would need to, be reviewing the proposals, but we typically come to this body and ask for a volunteer to be on RFP panels if there's a topic that's of interest. We assume that there is a lot of interest. I see Kimberly bringing us back. We knew that there would be interest, I think, from this group, and we would love the input of someone from this board on that RFP review panel.
And are we limited to one, or could we have two?
Tony said two, yeah, we wouldn't want to go more than two, just because RFP review panels, the more people we get, the more complicated it gets. We have to have an odd number, so we have some requirements that we have to meet. So I think two would be fine, we probably wouldn't want to exceed that, yeah.
Okay.
We'll have some criminal justice partners and some other folks on as well, so.
And were you interested?
Yeah, Melanie can go too if she wants to, she's got. They said two. That's fine, go ahead. Are you sure? Yeah, okay.
Okay, Melanie.
Yeah.
I think a quick update on that as well, just in terms of funding, this was not necessarily in the report, but I just want to share. Part of the funding model for the Crisis Now pilot, and remind it's a 3-year pilot, so this hopefully will be permanent. A big part of making this work is contributions from the hospital systems as well as the cities. We've been working with the cities for quite some time now. We've confirmed contributions, albeit somewhat small contributions from the hospital systems. We still do not have full confirmation from all 3 cities, and so that is problematic. We are operating a service that will benefit their residents as much as the rest of the county, and we believe it's something that we all should partner and share in. So we have confirmation from the city of Davis, essentially that they're in, they're good to go, they're feeling good. We have not heard back from West Sac after several attempts to get them to confirm, discuss, engage. I'm not saying this in a critical way, it's a big ask, we're asking for money. And the city of Woodland has tentatively told us they will only commit to 1 year of funding, although I've heard that might have changed to not being able to participate. We're trying to confirm some of those bits and pieces. So
Did you say Woodland?
Woodland is confirmed to 1 year only at this point formally, but I'm worried. It's a revenue issue. It's not a lack of wanting to try issue. Revenue measures passed in Davis and West Sacs, they're in a different position. But part of the success of this model is it's not just the counties, right? And so we have been trying to get the cities to sign on for over a year now, and we don't have all 3 cities signed on. So we're getting to the construction phase and we're getting a little bit nervous. This also may impact our ability to continue to fund CIT officers at a full cost in those police departments. We can't do both, I don't think, going forward. So some of this is newer information for you guys, and some of this will be information we'll be continuing to share with our city partners, but we need some skin in the game on
How much are you looking for from, is it different for each city or like for Woodland?
It's prorated by population. I don't know ballpark it. I think do you remember? Sorry, it's been a long day. My brain's been right. I can get you the numbers, but it's not an insurmountable amount. It's over a 3-year period of time.
And West Sac is the largest city, right? Or no?
Oh, man, my brain's right. I don't think it is. I think Davis is the largest. Yeah. So, but actually, that's a great point, though. Davis also, and they bring up a very valid point. Davis wants the university to be a part of this, and so we've tried to engage with the university. We've tried to have the university chip in. We haven't been successful in making really solid contact. So one of Davis's things is we really want, we've got 60,000 people, but 30,000 of them are students. The university should be at the table here. So we are attempting to maybe make that work with the university as well. But Davis has committed even without the university at this point, although they'd like the university partner. So, again, it's one of those things. Yeah, it is Davis. Davis is 66,000, Woodland 60,000, West Sac is 53,000.
Okay.
Is that 66 with the on-campus residents?
Yeah, I think they're included.
Yeah.
So, rather than have a discussion here, if you want to strategize, I have some thoughts and some people that might.
That'd be great,
help.
yeah.
If you want to.
Yeah, I think they're interested. Again, where we're at, it's also asking for money. So
When was West Sacramento approached?
It's been about a year for all 3 cities,
So changes changed now. They got Measure O that just passed in sales tax too.
Right, yeah.
So that could change things.
100%, yeah. So we'll keep reapproaching. We do keep asking, but just want to let this group know it's important that the whole community is invested in crisis now, because it's not just a county project; it's all of us.
Question. So with the expansion of the definition of gravely disabled, which I know we as a county have not adopted that, correct? We haven't.
Right.
Okay.
January 1st, 2026.
Right. So when that happens, are hospitals and cities aware that that is going to impact?
They're very aware.
Yeah.
Okay.
They're
Because
very nervous.
Cities
that
probably not so much. Cities.
The hospitals,
Yeah.
not city, the
because
hospitals.
I would think that, so I guess what I'm wondering is, hospitals are going to get impacted. And so I would think that they would be willing to pony up a little bit more money because their ERs are going to get impacted.
Yeah. My hope is that we show a real benefit to the hospital systems over the first couple of pilot years, and also to the wall time rates for local law enforcement. and that convinces them, hey, this commitment is worth ongoing kind of commitments to. But until we get into the pilot, they actually start seeing those results, it's hard to get them to commit. And I don't blame them. If I was them, I'd do the same thing, but that is the theory.
And so how does it work for Kaiser since our hospital is in Solano? Is it really only Dignity and Sutter that come to the table because they're the only ones that have hospitals?
So far, yeah.
And we've approached Kaiser, they weren't particularly, I mean, it wasn't like it was a hard no, it's just our efforts were focused elsewhere.
Kaiser has specific interests in West Sacramento, but not elsewhere in the county. So I'll just say that. But I just want to, because there's a hospital adjacent, in Sacramento, so they have a very particular census tract, I think, an area of the community that they're interested in. But I wanted to just respond quickly, Meg, just to really clarify, because the crisis receiving center that we are standing up will be a voluntary center, so someone cannot be on a 5150 hold. We have had some very light touch, I have had some very light touch conversations with Sutter in particular, but certainly with Dignity, about some interest in developing a CSU. We really do need a crisis stabilization unit in our county. Sutter is interested potentially in the future. There is Prop 1 funding available, bond funding for that. In round 2 would be a great round for a hospital system to apply for that funding. We would certainly be coming to the table as a partner, right, and wanting to contract for beds and signing a letter of support for something like that. So that I think is going to be critical when it comes to SB 4D3, because once someone's placed on a hold, they can't go to the receiving center. And so SB 43 isn't going to have, the receiving center won't have a positive impact necessarily on SB 43 and having a place to go when someone's placed on a hold under that expanded definition. So in our community, our hospital systems will be greatly impacted by that expanded definition. They also wanted implementation delayed because they are not ready for that either. And then the last thing I'll just say is that we are part of a multi-county implementation work group, which is sort of housed in Sac County. They did go live January 1st of this year. And so we are hopeful that we'll be able to learn sort of alongside Sacramento's implementation, which I understand is rocky at this point because they were not ready for implementation. So, but it's there's 7 counties participating in the collaborative. So, but there is quite a lot, I think, to do to prepare.
Yeah, and I think you're right, but Kenny, we do need a crisis
We need a
stabilization.
CSU, for sure.
And it has to be partnered with the county because you can't really do it privately, it's very hard,
Absolutely.
right? So, but I think there's just confusion because there's a lot. And so for people to
So
say
much.
there's a crisis now, there's a crisis stabilization,
Yeah.
there's this, and so then people start mixing and matching
Sure.
and so I'm sure your presentations are very clear when you're meeting with them and they know that, but I do think there's just dialogue outside of these where people
Totally,
start getting
yeah.
confused.
Yeah.
So I was just curious, but it feels like Kaiser needs to come to the table. I know you can't make them, but it feels like unless EMS is taking all of the Kaiser patients to Vacaville.
Yeah.
On this side, not.
They are.
Then I guess.
They do transfer to that. They do transfer to their own hospital, is my understanding.
So their
don't-
patients are not being held in our.
Not for a long period of time, I believe that.
If they can tell.
But does
They can-
Vacaville have a mental health unit? Because they didn't used to.
No, but I think that they then transfer from there.
Okay.
They do, they transfer from there,
Yeah. But yeah, I mean, my very general understanding, and when I've had a couple of conversations around this, is that once they are aware that someone is a Kaiser patient, they do transfer them, and then they coordinate for the next transfer to the appropriate facility.
It's just once they get to the ER, transferring them is really hard.
Of course.
So
Yeah.
if EMS,
Yeah.
if our EMS is saying we take them
Yeah.
without hitting an ER, great, I have no issue. But if they're going to our ERs,
Yeah.
then they need to come in.
Kaiser's definitely still on our list, and I think, again, once we start showing some data from the other hospital systems, and we'll have a different approach with Kaiser. We've had some trouble with Kaiser the last couple of years in YOLO on a variety of projects, not just this, and so I forgot I have a computer today, Chair, so I actually have the dollar totals. So we're attempting to get essentially $1 million a year from our partners, right? And so the county is chipping in anywhere from roughly $2.5 million to $3 million a year for the duration of the pilot. We are asked, that $1 million breaks down amongst the cities as well as Dignity and Sutter. So Davis, we are asking for $310,000 for 3 fiscal years. That's a total of $930,000. Woodland, we are asking for $280,000 for 3 years. That's a total of $840,000. West Sacramento, we are asking for $250,000 a year for a total of $750,000. Again, that's broken out by each fiscal year of the pilot. Dignity has contributed $100,000 per fiscal year, and Sutter has contributed $250,000 for a total of $750,000. So again, we're trying to build this as a collaborative model. Davis has committed with or without UC Davis at this point, and we're still working on Woodland and West Sacramento. The Woodland, like I said, is committed to the first year, but that's about it.
We need to hear about this at the Health Council too, because the people who might be able to get somebody in West Sacramento to care and give an answer may well be at the Health Council. Okay?
Have you had a crisis center presentation? Do you know?
We have not.
Did a Prop 1, yeah, I did a Prop 1 presentation.
Yeah, we had,
but not
I'll
a
work with
crisis.
Brian.
not a
now.
crisis now one, and I think
We
they
did
would
have a
be
joint
excited
meeting, though.
about it, and I think there would be perhaps someone there who's got some connections in West Sacramento that might be useful.
Remind me that the cost of a co-responder, like, I know that we pay half, and we
pay about 2/3.
That's
I'd say.
Or more.
Services
It's
they
not
pay
more.
half.
Yeah.
Yeah, they pay $60,000, so each of our city partners, or the CCP for the shared, co-responder who's embedded with probation and the sheriff, they contribute $60,000 a year towards salary and benefits, with the fully loaded cost of a clinician, a co-responder clinician that's not half, it's not even close, so I would say it's a third or a quarter if we're thinking about the fully loaded cost in terms of our benefit structures and some of those related costs. So we've been estimating it that it's about a 30% contribution, but it really does depend. It also depends on the salary level of the employee, if they're licensed or not, and those kinds of things.
We fully fund the supervisor, the manager, or all
Yeah.
of the ops equipment, the vehicles, the equipment.
But it's certainly, I mean, it is a shared financial
It is.
model, and they do contribute each city for each co-responder, $60,000 a year.
And did you say you were going back to the hospital to ask for more, or what they've given is what you've asked?
We're gonna stick with that for now. We plan on, hopefully with some amazing data in hand, requesting more at a later date, but for now, we're gonna leave it there.
All right.
Sorry.
Yeah, go ahead.
Something I just kind of wanted to add to this conversation, again, I want to emphasize the importance of eventually, this is probably way in the future, but eventually looking towards having a crisis stabilization unit within Yolo County, because from a consumer perspective, the outcome and the user experience is much improved than hospital emergency rooms. And I think that goes for both patient experience and also for staff experience as well. And I actually kind of did a deep dive into like outcomes, like long-term cost savings, and trying to look at preliminary results of some of the studies that I read were very clear in terms of obvious benefits of a 5150 capable crisis stabilization unit versus something like a receiving center. So that's something I want to add.
All right. B, leadership transition.
Yeah, I think, Carly, do you want to dive in on that, or do you want me just to dive in? Yeah, I think Carlene did a wonderful job documenting the coverage plan for where we're going to be heading. I think Christina may have also sent the local mental health board an email up, did she? Yeah, that you all received. So I wanted to share a couple details, just so you know kind of what I'm thinking. And I think I know everybody. There's not, I'm Nolan Sullivan, I'm the Health and Human Services Director. I work with Carlene and Tony. So Carlene apparently has size 9 shoes, and they're very big shoes to fill. I learned that today.
Literally.
So we are looking to fill, Carlene she's just an amazing human being, and I've been singing her praises and mourning the last month or so. So I echo everything and appreciate all of the comments from you guys today and share all of those same sentiments. Simultaneously, as her boss, it's an almost impossible task to fill her role. So we're looking to obviously figure out how to do that. I have a meeting tomorrow morning at 10 o'clock with a recruiter. We don't usually use recruiters in the county for most positions, but we'll be doing a nationwide search for her to really look for a good pool of candidates. Obviously, if I had a clone of Carlene, that would be great in the sense either herself or her skill set, right? She has been the public guardian, the mental health director, the assistant director. She's got child welfare experience. She's got adult experience. So we're gonna be looking for, a candidate to come close to those fits. If by chance we don't find that, I don't necessarily have to have this role be the same. I talked with Jonathan a little bit about this too. The assistant director doesn't have to be the mental health director. They don't have to be the public guardian. So there is some flexibility. So I am looking ideally for someone clinical, but if I don't find that, someone with amazing leadership or good skills in that area, and we can kind of figure out some other bits and pieces. So we'll be launching that recruitment in the near future, ideally as soon as possible. And as Jonathan mentioned earlier, we were very lucky to have Joan Fennell kind of come out of retirement to help us out. And so Joan, I'm kind of describing her as an executive project manager. She's kind of keeping the wheels on, keeping things moving, supporting us with some of these higher level projects. Some of you may know Joan, she's fantastic. She's got 30 years of experience, just a really great person. And I couldn't be more grateful to Tony. Tony has, I think Tony's plate is beyond overflowing already. And Tony has stepped up and volunteered to take on the mental health director role. So part of why that made me so happy is he's been shadowing Carlene incessantly for the last probably year or so anyways.
No, I tried 9 years.
9 years. And he knows her best and knows all her different things. But I know that he's well liked and well respected and really knows the local mental health board. So he was a really easy choice for that role, mostly because I know he will support you well. Carlene's done such a good job of kind of repairing the relationships with NAMI, with the local mental health board, like we all talked about earlier. I think Tony will carry that torch very capably. And so that was an easy fit for us. So Tony has, I think, 7 jobs now, and I'm gonna try and get him some help, but he'll be a great replacement. So.
For juggling lessons.
Yes, yes, we will be hiring professional juggling coaches for him for sure. So he'll be stepping in kind of seamlessly. Christina will continue to be an amazing support for this group. So other than Tony and Carlene, you should notice a whole lot of changes. Bear with us a little bit. We're down a couple hands on deck. We actually have a few other executive vacancies. So if things are a little slow, we're not making as much progress on things, or we're saying no about things, it's nothing personal. It's just we're going to be struggling the next couple months. It's not just Carlene. We have a couple other core vacancies we're filling. So that is the coverage plan at this point in time. Again, Marissa Green, if you're worried about public guardian or public conservator, has volunteered to take on the public guardian role, which is great. She's been overseeing that team anyways. She's very sharp. She's got a great social work background. So our folks are in good hands there. So anyways, that's the interim coverage plan. If any of you know folks that could potentially try to fill Carlene's shoes, and I say try because it was very hard to do, I will share the flyer with all of you and make sure that we get this out far and wide. I would love to have you kind of share it with your networks as well. And then as Jonathan said, there is a very vague line in the Welfare Institutions Code that the local mental health board has to be involved in the selection in some way, shape, or form. And so what I really prefer is a person or two on an interview panel. I'll probably have a very robust panel with ideally maybe an executive panel that includes folks, maybe executive directors in the mental health field, maybe someone like Jen or others on kind of a screening panel. That probably would also have a member or two from the local mental health board. And then I'm gonna get kind of creative and figure out a few other things. So it'll be a very difficult and robust interview process. I'd like to have some employee voice as well. I really think that's important. And so I will be contacting whoever the chair ends up being at that time. This is probably gonna take a while. I wanna set expectations. Nothing moves quick in the county. I'm probably guessing April-ish. But I will certainly have involvement from 1 or 2 of you, and we'll consult with you through the process as well. So that's the game plan. And again, any assistance, support, or just patience during this time would be greatly appreciated. I know Tony's going to do an excellent job, but just bear with us and hang in there for a couple months while we fill all the gaps. So.
Thank you, Nolan. I don't think anyone holds C.
Well, actually, if I could ask a question.
Yeah.
Yeah. Are you looking at reorganizing to make the workload more sustainable?
That's a good question. I don't know if we can make them more sustainable. I mean, it's a resource problem, right? And so the other piece, and it seems like whenever I come to this board, I share bad news. You guys should stop inviting me.
But you brought pizza.
All right, pizza's been offered. So all of this to say, this is under the guise of the county is actually officially in a hiring freeze as of today. We are making 7% general fund cuts for our next year's budget. The BHSA budget, like we went through, is a complete mess. And so it's not a problem of choice, it's a problem of resources. And by the time this meeting's over, I'm sure I'll have 2 more emails from DHCS telling me different things that we need to do without any staffing or additional resources. We're trying to stand up crisis now in SB 43 in Cal-Ain. now we've got a hiring freeze and we've got funding issues. And so we are looking at reorganizing things a little bit, but frankly, just the pace at government mental health services is unsustainable. And so I am trying my best to sort of lighten the load, rebalance a little bit, but I don't have any brilliant ideas on how we're going to really solve that. So we're gonna try, but it's really hard right now. And I don't see it getting a whole lot better over the next couple of years, but we're gonna do our best. And so, I hate
Because
to
you're gonna burn out another director if you do.
Yeah.
well, it's either I say no, like we don't do SB 43, we don't do crisis now, we don't do, and then we have the community up, it's, you can't win. And so that's the challenge that we face in local government. We constantly have more demands and expectations and we never have enough resources. And I think we've all been on both sides of this. I mean, we had a meeting the last time I came, folks were saying, why don't you do SB 43 now? This is why. Because we're burning our people out and we can't do it all. And the cavalry's not coming, there's no resources per se. So it's depressing, but it is what, but we're doing.
That money from those parking meters?
I wish we could, I wish.
I was like, why can't we get
Yeah.
some of that money?
Well, we talked about Yolo County's funding, we talked about all of it, it's like, we are a really low funded county too, and we don't fund mental health services, we've got a $6 million structural deficit. It's really hard, it's really problematic, but gosh darn it, for the team that we have and the under-resourced, and we kick butt, we do, I mean, I know we could do more, but I mean, for what we
Now
have.
we're losing some of the team.
Right,
We have
right.
a fantastic team. I
We
want
do.
Yeah.
to keep as many of them as we can.
But that's
You're hardly.
that's the hard part, right? And I, it's a really hard workload. It's Herculean and it's, so I'm gonna do my best. Sue, the short answer to your questions, I'm certainly gonna try. I don't see things lightening up though. I mean, it's only getting harder in county land, especially on the mental health side of the house. DHCS is relentless. And consumer demand and expectations are rightfully so, but also relentless. And it's hard,
Can I just add something? I appreciate y'all for talking about my workload, but I just want to say that I am one of many people in the county and in HHSA who has far too much work than there are hours in the day, who experiences such tremendous pressure that it's overwhelming. You know what I mean? Nolan included, Tony included, Julie, who's incredible, sitting in the back of the room here included. There are many of us. And so, and unfortunately, the fiscal future doesn't look great. What we need is better internal infrastructure to support the amount of work that's coming to us at any given time. And that's what we don't have. And when we cut, that's what we cut. Because what we can't cut or what we, don't want to cut is our client-facing services, of course. But what we lose is those positions or resources that feel nice to have, right? But they really are critical. And so I know that no one wants to make our workload more. It's not a matter of not wanting to. And the state has been relentless. For every new legislation that passes, there's of course a lot of joy that comes along with that because it means it's going to improve something or change something in our system. And for us, it often comes with no funding to support it and a tremendous amount of work. And not a lot of resource, which is just challenging, and there's a mental load that we carry around with that, and so I just want to say that we have an agency full of people who are working far more hours than they should and sacrificing. And so, so I just want to acknowledge that because it is absolutely in no way just me. And it hasn't been. These problems have also predated my time here, these are long-standing problems in our system. And I know that no one wants to make it better. And we also, I think, have to face the realities of the resources and the challenges that we have, which are significant, and so I just want to acknowledge that. And I also just wanted to take the opportunity to acknowledge that Tony works far more hours than one human being should. I mean, we are all pushing ourselves beyond our limit. So I just want to say that.
Yeah, and I'm definitely not trying to.
No, glad you brought it up.
Make your job more
Yeah.
difficult, but
And what happened, I think, and why it's so hard to think about it this way, is that we were really in a huge hole. I mean, I've been on this board a long.
Yeah,
20 years.
that's right.
We have worked, and the COVID money gave us just enough of a look at what it might be like to be out of the hole. And then it went away. And it went away right in the face of all this other stuff that we had to do. And I think that's at least a part of it, is that we almost got to see what we might be able to get done.
And everything is pretty much running out now. It's, you know,
Yes.
that's where we're at. I think, you know, we've never had more employees on stress leave, on mental health related leave internally. I mean, I see it every single day. This is not normal, you know, and so folks are burning out. It might be helpful to have a session, and I'm not sure where we'd even go with this, but like on the mental health of the mental health workforce, or you know, we're really focused on something called healthy work in our department in particular, really looking at these sort of emotional and mental aspects to the job, because it's grinding people up, and I don't know how to fix it, but it is probably the biggest challenge of my career, and it's a real thing. But wú helps the people that help? You know, I don't know. It's a tough one. So
Yeah, and
something
if those
they
are people who
started
were
working
in COVID, that was a help for helpers
right.
thing,
Right.
that, what was it, UCSF was.
It might be healthy work, which like when we
Yeah,
presented.
oh,
health council,
okay,
yeah,
okay.
Yeah, so we've started that, but it diagnoses you have a problem, but it doesn't necessarily help you fix the problem.
I see.
So we have a very healthy work relationship right now with work as an agency, but we don't necessarily know how to solve it. So it's, but it's the first step in that, you know.
That may be more than one county agency too.
Yeah.
Because
Absolutely. Yeah, it's not just the Health and Human Services Agency, you know?
All right, okay, if we move on.
I did bring pizza, so like.
And cupcakes.
Thank you for that.
Yes, and by the way, cupcakes,
Sugar
everyone,
tarts.
I was gonna take like a 5 or 10 minute break, but I'm looking at the agenda and I'm not so sure we'll have time to do that, so everyone get up as we're going through this, feel free to get up and grab a cupcake. Or we can pass them around too. So, no one wanted to call C, I think, unless I'm mistaken. And unless our folks.
That's fine. No, there was just information, just to let folks know we're starting the planning for the next annual update for mental health services. That was it. Yeah,
You're gonna miss it.
so much.
D, Chris called this. Chris?
I did, just from looking at the minutes from last year reminded me that we did have a attempted referral to care court for a person that was a 1368 status on a misdemeanor and didn't get a response from the county. And Judge Wolk ended up dismissing the case because it was voluntary anyway. And so I believe looking at the care court implementation, because the 1368 population, when I was looking at over a 3-year period, 14% of those individuals went on to commit a felony and go on to 1368 status and with the IST cap. I just want to make sure that there's an avenue for the court to make the referral, the criminal court to care court. The judges didn't seem to know how to do it internally themselves, so it's got the court referring to the court. But the DA's office, for example, doesn't have a role in that. The public defender's office doesn't until the petition's been filed. And so there's a gap there last month, and I just wanted to bring that up and try to figure out what that referral process was.
Yeah, I mean, so I'm Julie's here.
I know
I'm
Julie's
sorry.
there, and she sent me a presentation, and I couldn't figure it out from that.
I mean, she's our lead on the CARE Act implementation, but and maybe this is a conversation to have offline from the local mental health board meeting, but I am not aware that we would have responded to something. I know that we received an incomplete referral from the court, and when our council responded to the court and said, this is incomplete, they said, well, this is what you get, and we still move forward, right, with following through with it. And so I am confused about where things would fall through the cracks, because we have a legal obligation to engage in the process and begin the assessment. I think, I hope that the courts can become more familiar with the forms and filling them out correctly, because it does make our team, and when I say our, I don't mean me, I mean Julie and her team, their work much harder when we're getting things that are incomplete or not accurate, but we're certainly still moving forward. Julie, do you have something you want to add to that? Or?
No, sorry, she was just saying.
No, it's
like,
okay.
Julie, and
Just
I was
gonna
like,
say,
yes,
Julie,
I was-
that is
I was-
Julie.
I was like,
She's
no,
amazing.
I was just gonna say, I don't know, which, particular person talked about, but if it was like he responded on to orders from the court, and we didn't get an order for that
Yeah.
particular person.
Okay.
So, yeah, but I think that, process needs to be a collaborative, like, we need to work on that process from the courts, the ISD referral. We definitely need to do that.
Yeah, but that's one of my pet frustrations with the misdemeanor ISD. And that the care court is one avenue that the judges have. I'd kind of like, from my perspective, I'd like to see, if it's possible, kind of like a year-end report on the number of referrals to, say, the public guardian or to the care court. If it's possible, get what happened, did they engage? Were they
I
served,
mean,
not
CARE
served?
Act has only been live for 5 weeks.
I know,
Okay,
I know.
just make
I'm
sure.
saying it
Okay.
a year from now.
Sure,
It's
okay.
kind of,
I see, you're
not
giving us
next
homework for
week.
next year, guys, yeah.
Just kind of going
I just wanted to
forward.
make sure I understood.
I'm going to pile on more work. Tony's looking pale right now.
Just don't turn the lights out when you.
Nolan,
Tony lives over this.
Nolan and Carleen, have you tried to meet with the court?
So, I want them,
Or
so
Julie,
it's not
or
mine and
Julie?
Nolan's, yeah, I will say Julie has been the lead on our CARE Act implementation from its inception and has worked very closely with the court and particularly with the self-help center with the court. So there is quite a bit of engagement happening.
The self-help isn't gonna help you with the judges.
No, but
The courts are involved, so the two analysts that work for the courts, they are so far ahead of HHSA in terms of their planning.
Okay.
So by the time it came to come to the table for our work group, they were like incredibly helpful. And so and that's one of the processes that we know, the IST process. And in fact, I have a meeting Friday to kind of discuss that a little bit more with our care consultant to talk that through a little bit more, because that's one of the processes that we didn't fully flesh out at the launch. So we're still working on it.
Because it's always a challenge to
Yeah.
get the judges to do things the way they're supposed to do them, because they often don't care that much, and they just do what they want, and they all do it their own way.
That's right, and if it's coming from criminal court, it can be coming from a number of courts, the same issues that we'll face with Prop 36. So I agree, and I think we're in very early stages of implementation, and so there is a constant sort of course correcting and refinement process happening, and all of that is in Julie's incredibly capable hands.
I think the moral of the story though is if anyone wants to map out the scenario, Chris, you want to put that in email,
Yeah,
we're happy to chase it down with those contacts for it.
Okay.
Yeah.
Okay, the reason why I'm wondering about it is because you had said it would be nice if the judges kind of knew how to do it, you know? And so if they don't know how to do it, it's not always easy to get them to do it the way you're supposed to do it, but, you know, I was just kind of thinking in my mind, reaching out to the presiding judge, Judge McGuire, or I don't know if they still have the quarterly collaborative meetings, you know, that might be a good place where those
Care
judges.
court hasn't been
We've
in
been in
those.
communication with the court about
Okay,
the
great.
issues. And they've told us, they've assured us that their judges are trained, so we're gonna keep working.
Yeah,
I mean, we're
Working on
right,
that.
we can only do so much, and I will say the judicial council did receive funding to implement, to support the courts in implementing the CARE Act, and so I think our hands we can only go as far as the court system will allow us to. And yeah, it would be nice if things were sort of buttoned up, and we know this is all brand new, right? We're learning right alongside everyone else, and so anytime you roll out a brand new process like this, there are certain, to be sort of some bumps in the road. I think considering that the bumps have been quite small and few and far between so far, and so, so I think there's just some growing pains, but we're certainly working through it.
Can I say one more
Yeah,
insider
please.
piece of knowledge
Yeah.
too, that for cohort one, cohort one had to create all of this. And so for cohort two, it was much easier for us because we got to benefit from all the resources. But one of the things that has not been fully fleshed out until I got it in my inbox yesterday, I think it was that the IST process and the public guardian process.
Yeah.
So they created a behavioral health workflow resource that we're now reviewing. So yeah, things are kind of trickling out as they do with the state. So,
Thanks, Julie,
Yeah.
that's so helpful.
yes.
So glad you are listening.
I'm here for you.
Thank you.
John, do you have a question on this?
Nolan?
I just wanted to, reference under who does the program serve. The very bottom sentence talks about the respondent was detained for a minimum of 2 periods of intensive treatment within the last 60 days. If you go and you look at the petition itself, there is an or to that. So in my case, I plan on filing. I have an appointment, by the way, with Daniela on Monday. But my person no longer fits the 60 days, so she's gonna fit this or. And so that or it would have to be for behavioral health. So how would somebody like myself, if I go on Monday to do that, who would I talk to get that, the piece that needs to be signed off by a behavioral health person?
Push that, yeah.
They'll still
push
push
that
it through.
They'll discuss
Yeah.
that part with you, and if you fall in that order, they'll explain to you how,
Okay.
like, that part of the process.
And you mentioned that earlier.
Because if you're the petitioner, then it goes to the court, and then they review for, the FASHA, and then they'll send us an order to evaluate. And then that, mental health declaration will come directly from us.
Got it. Thank you. I just wanted it to be noted as well on this, when you guys see this, there is an or for other people here.
Thanks, Melanie, and we can update this, I took this straight from our website, so we can certainly update the information.
Yeah, we do need to actually update that.
Yeah.
because of- yeah.
Yeah, so we'll make sure our website's updated to include that more information too. I appreciate you.
Thank you.
bringing that up.
Yeah, because it's gonna be, I don't know if I have that much faith in care court, because now you gotta get the person there, so that's gonna be a problem. And it'll be interesting to see where we are a year from now, to see how many people were we able to engage to get into this process and get to see a judge and then see what happened after that. Because at this point, if they're not responding for services, or if we're not able to engage them, how are we gonna get them to the courthouse? So, yeah, it's pretty frightening. We'll see what happens.
Where were you looking at that with the or, what?
Oh, you will see the or if you go into the actual page that you
So this
petitioned.
came from our website, so that's what I was just saying. This came from our website and we need to update it to add that or to it.
Where is that section?
It comes
Who's
after,
the program serve last bullet?
it comes after the who does, where it says respondent was detained for a minimum of 2 periods. There's an or after that, that's not included.
Wait, response and.
And the most recent episode being within 60 days, there's an or and then another item
Oh.
that we don't have on that's missing. So we'll make sure we have that.
And it is on our website on the one page, it's just not on that particular page.
It's not on the page I pulled it from,
Yeah.
Okay,
which is like on the main page. So,
Yeah.
Yeah.
okay.
Sorry, question, just more procedural. So you know how to do cleanup bills, like they need to bill them in.
Mhm.
This, because this is part of the health and
Omnibus?
welfare code, did they clean this up? Like, did they go back and say?
There's already a cleanup bill that got pushed forward, but that actually just required more tracking and data. It didn't clean up, it didn't actually clean up anything that we would consider needing cleanup. It added more requirements to us so far. But yeah, there are frequently cleanup bills that come through that then will clarify language that, maybe doesn't make sense once implementation, or adds more requirements for more reporting or clarify something. So there already is one, I think has been pushed through.
Especially when voluntary, involuntary, if you can't get in there, and you have to run up
That's
to
right.
50 because they don't qualify.
Sure.
That's a gap. I'm just curious.
Yeah.
Okay.
Okay, on to, item E.
Yeah, so similarly to us requesting, and certainly this is optional, I just want to be clear, this isn't something that anyone's, it's a requirement, but we have added a crisis manager position, which has been, that's really great news, it's great progress for us. We have a clinical manager right now, Mario Galagazzi, and he is over access, wellness, and crisis, so he is under his purview, sort of holding a large portion of our adult behavioral health system. And so some time ago, we were able to create a new clinical manager position, which will be over crisis services. We have completed the recruitment. We're ready to start moving into interview panels. And Tony had asked that we include to the local mental health board a request or an opportunity for someone from this board to be on one of the interview panels to interview potential candidates for this crisis manager position. And just for this board's knowledge, the purview for that person will be our existing crisis team, so that includes our co-responder clinicians, our clinic-based crisis. It will also include components of Crisis Now, so overseeing the contract for the operations of the Crisis Receiving Center, overseeing our contract for after-hours coverage with AMR, with our ambulance provider, likely overseeing aspects of our high-tech call center contract as well, and then our contract with Safe Harbor for crisis residential. So really bringing our entirety of the crisis continuum on the adult side of things under one manager. So we have a list of folks that meet minimum qualifications to interview. So Tony is putting together the first panel now. So if there is someone from this board who would want to participate, we would welcome your participation in that interview.
All right.
So
I just don't have a
Jonathan,
clinician background, but I mean, it wouldn't really
we're
matter,
not, yeah,
right?
we're not seeking someone here for having a clinical background, right? We would be seeking someone to provide whatever perspective it is they bring to the board, whether you're someone with lived experience or you're a family member of something, you know, that's really the perspective that we'd be interested in, no matter what your perspective is and your interest. We know that the work under this person is, I'm sorry, we also put our CIT training that we do for law enforcement. So we know that the work under this person has been a high priority area of focus for this board. And so I think Tony, in a very good decision predating his appointment as interim mental health director, suspected that you would have folks from this board interested in participating in the interview process, and we would appreciate your input.
All right, so you got Kimberly?
Yes. And Melanie's interested too. So perhaps what we can do is have a list of folks, because I know with scheduling, it can be difficult.
Right.
And so.
I think the other thing too is we want to figure out the right size of the panel. There may be multiple rounds, so there might be opportunities for
For someone to be on the first round.
I don't want to make any promises or anything like that right now, but like we also want to have other partners participate as well. So.
So we can do both names and we can figure it out.
Right.
Yeah, well, you know, you got two of us, if you need us, so.
Okay, great. All right, so.
And really quick, I mean, Sue, this is an example of how we're trying to expand capacity, right? It's a brand new manager position. We're kind of adding some capacity. Carlene's actively writing RFPs for crisis now. That should not be happening. So this manager would take some of that load. So, you know, we have been able to add some positions and the board's been supportive where possible, but you know, it's small victories. So this is one win for us.
Okay, EF. That was.
I was just curious if I'm reading this correctly, it sounds like you guys were pretty well staffed for psychiatrists and, physicians.
For prescribers, yeah.
Yeah. Are you noticing like wait lists are we seeing that patients are getting in because of this?
Yeah, we have quite a bit of capacity. And so I think what our data shows around prescriber availability is, we do provide both in-person and telehealth services. Our in-person services definitely fill up more quickly than the telehealth appointments, but we are able to offer first appointments within the timelines that were required. And even if we have urgent appointments, we have capacity for that as well. So we are well staffed in our prescriber area. The one thing that Dr. Devin didn't note here, but I know is on the horizon for him. Right now, we do lean somewhat heavily on contracted psychiatrists and prescribers through locum tenens, which generally are telehealth providers, but we do have some in-person folks as well. And I know that he would like to bring a little bit more balance to permanent full-time employees. And we do have several county psychiatrists, but we are definitely supplementing that workforce with locums. Yeah, but we've had long-standing locums, so we don't have a lot of turnover there. So we've had folks who've stayed on for a couple of years. But I know that the next step that Dr. Dunto would like to do is bring on another full-time psychiatrist and then reduce our utilization of locums, sort of naturally there. But we do have a very sort of solid base, which has not always been the case. So I do think that is something for us to be proud of in terms of being fully staffed with psychiatry. Mm-hmm.
Okay, right onto the regular agenda. Actually, yeah, regular agenda. Board of Supervisors.
Yes. Hello, everyone. I'm Oliver Snow. I'm here from Supervisor Sheila Allen's office. She's the new supervisor that was just sworn in on Monday, so excited to be here as a deputy supervisor. Just really briefly, I want to add to the chorus of thank yous to both Colleen and Chris. I know Chris has done a ton of work with the DA's office in the mental health one, so the board of supervisors is very grateful for all the work you've done. I know Colleen, I know Supervisor Allen was very sad to hear that she'd be leaving, but she does have faith in Nolan and Tony and Marissa. The HHSA team to fill that gap. So thank you for all you've done, Colleen. Just two quick updates about the board meeting next week. There'll be a presentation from the Yolo County Housing Authority on their strategic plan sort of process that they're bringing in. So that might be interesting to folks. And then if you haven't gotten the message yet, there'll also be a brief budget overview update talking about the county finances in the budget year. So that will probably be depressing, but it'll hammer the point home. So yeah, thank you everyone.
Hey Oliver, question for you. So is Sheila Allen gonna be, take
Yes,
the spot of
so
Jim and be the,
they're confirming the committee appointments next Tuesday, but from everything I've heard, she'll just be taking over Supervisor Provenza's position as a liaison to this
great,
behavioral health board. So
great, thanks.
thank you.
Thank you, Oliver. Thanks for coming. And now the criminal justice report.
Which will get more challenging in the future. But what I do plan to do is to reach out to my replacement and also the supervisor for the public defender mental health team and try to get information from them to give the board on what they're seeing on the mental health side from the criminal justice side. One of the things that's happened in the last year is that we're seeing more involuntary medication orders in the jail. In other words, a psychiatrist who's overseeing a treatment of an inmate is recommending that a judge do an involuntary medication order because they're finding that person is a danger to themselves or others. And then the judge has to find that evidence to be true by a clear convincing evidence standard, which is the middle standard in legalese, which probably doesn't make any sense to anyone but Jonathan. But anyway, so you have a court order finding that this person needs to be involuntarily medicated. And so we have had a couple of individuals that are in 1368 status where they're incompetent to stand trial. And they've been on misdemeanors, they've been referred to the public guardian's office for a referral. And those referrals have been rejected because a lower level of services hasn't been attempted. And so then those criminal cases will be dismissed. There's nothing else that can be done with that individual. So that's one of the things we've seen. We also have a referral pending to the public guardian's office for an individual that has been found incompetent to stand trial, 4 separate felonies in the last decade. And that would be a different approach to try and get that person more long-term engaged in mental health services as opposed to we'll send that person to prison and they'll come back and we'll probably just start over again at some point because that's been the pattern. And so one of the things that we've been doing on the criminal justice side as a deal with mental illness is to try and utilize that resource. We haven't been real successful. We've been successful in some cases, but others, more often than not, they haven't been tried, say, at the full service partner level yet. And until you fail at that level, you can't move up to the conservatorship. I know some individuals on this board have had family members, and they've kind of approached this from a different way, hoping that their loved one will get conserved so they can get services. But that's just something that we've seen coming out recently, and we're trying to change that approach. I'm hoping the person that replaces me has the same attitude and approach to it. I think he does. And so that's just kind of my last one from being in the courtroom as a DA. I'll try to get information to bring to you guys in the future.
Chris, can I ask you a question? I know that the probation was understaffed in terms of going to the jail to assess or interview FSP clients. Are they back up to staff? Do you know?
They are, as far as mental health court, they're back up and doing assessments. I reported that at the last meeting, that they're back up and doing assessments. So the mental health court program, if they have about 22 people in it, they can take up to 30. And it won't be a quick fill because it's a very challenging population that actually has to have the right insight for that program, so not everyone's right for it. They also have to be at the FSP level of mental illness. So that'll probably take about a while to fill up.
And do we still have an issue with individuals that are FSP that are on the wait list waiting to, do you know?
I know that the FSP numbers are downsizing. I believe it was the 200 Carlin reported. I don't know if we have a wait list issue like we had in the past. I don't think we do at this point.
Chris, who is your replacement?
Preston Shaw.
Preston Shaw.
And I did speak that he doesn't want to come out here and introduce himself at some point in one of our meetings. So
You can also do it by Zoom.
do it by Zoom too.
Okay, now we're up to the ad hoc committee reports, and we have the site visits, and Kimberly's gonna talk about, what, right?
Yeah, I thought we'd done this at some point, if I'm
Yeah.
not remembering correctly.
Wasn't it
Like in November?
Yes.
2 or 3 meetings ago, she talked about going out?
We haven't talked about receiving the full.
So here's why I put this on here. I missed a couple meetings, but, so it's possible I missed that meeting. However, you provided some really robust documents detailing. I know those came after the meeting you might have presented on. So I had assumed that you hadn't done sort of a more robust report based on those documents that I thought were really great, but maybe you've already done it.
I'm happy to kind of go over it again and answer any like further questions on it. I can kind of go over like 2 points again. Yes.
Okay, go ahead.
Okay, yeah, so this was on September 16th, so a bit ago, but Sarah and I went to Safe Harbor and did our site visit, and then afterwards we took notes during the visit, and we also kind of like provided a write-up of kind of our impressions. And in terms of, then we met with the clinical director, who kind of gave us a brief tour of the facility. And we also were able to meet with a consumer who was at the facility and talk to him separate from everyone else to get like his impression. I guess our overall impressions were staff were compassionate and friendly, and that they were helpful and understanding to the clients. So Safe Harbor's main goal is, they stated it as like psychiatric stabilization, restoring the client to like their previous level of functioning. And they do a very detailed biopsychosocial evaluation upon client admission to the facility. In terms of what the clinical director said were the biggest obstacles for people upon discharge, the biggest challenge they face is housing, so kind of finding a placement for them after they leave. And then in terms of client experience, they reported that kind of like their experience with the staff was positive, their experience with the programs was positive, but then they could perhaps have like better equipment in terms of like, just like recreational activities. And something that Sarah and I brought up specifically afterwards upon review of everything. So this is like another, like, I guess, kind of like resource gap in terms of how sometimes resources don't know to refer to each other. So county area psychiatric hospitals and also like EDs don't necessarily know to refer to Safe Harbor, or really functionally sometimes even what Safe Harbor's criteria is for admission. So we observe kind of like a direct gap there. And then also upon talking to the clinical director and to the consumer that I spoke to, they don't have a formalized way of collecting client feedback after the program. So they collect data on some outcome, but they don't really have like a specific way of collecting client feedback. So that's, I guess, like a summary of all the notes that we took. Yes.
Question, so I hear this, it's applied to others in the community. So in this report, they talk about those in crisis.
Yes.
How they are discharged. So there's people that are perceived as in crisis but don't meet 5150 criteria. And I think it's somewhat confusing to me. I mean, I understand 5150 criteria, but to me to say someone's in crisis, it doesn't, I mean, I'm not a clinician, right? So I'm not sure, but it feels like there's a gap there. Like if we have people in crisis, but we're discharging them with a bus pass, that doesn't, I can't wrap my mind around that.
Yeah, I'm not sure what the feedback said in the report, just to be clear. Folks are not on a 5150 hold when they're at Safe Harbor.
Correct, but they were talking about their struggle is that Safe Harbor believes there are people being discharged out of ERs that are in crisis.
Oh.
But they don't meet 5150 criteria. So I guess I feel like there's kind of a gap there, like there's probably a definition of in crisis, I'm guessing from a clinical standpoint, but you may not be 5150 criteria.
Yeah, I mean, we don't have a lot of control over who the ER is discharging and what they're doing when they're discharging. I mean, I do know that the hospitals do have contracts with YCCC. It sounds like there could be some strengthening and improvement in the coordination between ED discharge and utilization of Safe Harbor. I know that utilization of Safe Harbor by some of their contracted partners besides the county has declined quite a bit over the years. And I think I know I presented data to this board at some point that there were many days where Safe Harbor had 0 residents. We were paying to hold 6 beds on any given day, and we had many days that we paid for 6 beds and there was not a single person in the facility. And so we've been working with Safe Harbor on, just from a county perspective, on their admission process and criteria, and we put some refined language in the renewed contract that we executed with them last year to have quicker admissions with a lower bar, sometimes because sometimes there were exclusionary criteria that we maybe disagreed with, so really working with them on some of that. And that's going to be really important for Crisis Now and getting the receiving center up and running, because we know that there are going to be folks who cannot stabilize within 23 hours in the receiving center. And what we wrote into the contract is that they would accept direct transports from the receiving center to Safe Harbor and have admission. So, and there's been limitations on the times that they would admit and some other things, right? So we've been working on that for quite some time. And it sounds like there is some opportunity to strengthen communication and coordination with the hospital systems, which I can't speak for the hospital systems, but I know they have their own relationship and history with YCCC.
Right, but so I was just curious about the in crisis. I keep hearing it, and families will call and say, I have a family member in crisis, and I don't know what to do with them. So that word gets used.
Is there a definition? I mean, I'm kind of feeling like crisis just means the layperson they're in crisis.
I don't know what to do.
I would ask them, I would ask Safe Harbor what they mean by that.
Let me ask, I want to ask a question about the lack of usage.
Yeah.
I feel like someone should be telling Safe Harbor, like, you almost got cut, right? And then we added back those beds.
Oh, they know.
Yeah. Well, I know they know that. I'm just saying, let me finish.
Okay.
You guys got to market, like, what, because I was thinking, who isn't the pub, referring individuals, agencies, sounds like they aren't maybe aware that there's this great place that they can send people to. That's what I'm hearing. And I was thinking, well, who should be doing that? And I was, initially everything goes to you guys, but it seems like Safe Harbor, for their own survival, like they need to be getting out to the hospitals or wherever and letting them know there's this service, because, otherwise it's like, we almost cut you before, that, but, if there's going to be 80%, 100% of the beds open, we are going to have to cut you. And you know what happened last time? They were saying, we can't survive if you cut us.
Yeah, and again, and I don't want to speak for the hospitals, but I do feel confident saying that they are well aware that Safe Harbor exists.
Okay.
They have long history with YCCC, so I think there are some other opportunities here. And I will just say, Tony and I have recently been, I will obviously not be in the future meetings, it'll be Tony, but we are meeting with leadership at YCCC to have some discussions about a number of things. And so this is a timely conversation, because I think this will be very relevant information that Tony can take to that conversation. So I will just say that we've met with someone recently to talk about some challenges that YCCC is experiencing, and Tony's going to be working with some internal folks and with leadership at YCCC and a community member who is trying to provide some support to them. And hopefully we'll make some headway there. But these are topics that we've discussed with their leadership over the last several years. And, you know, this was the hot topic my first meeting, right?
Yeah.
I mean, this is when I was in the hot seat, right? And so,
Appropriate to bring it back around.
it is fitting to be talking about Safe Harbor at my last local mental health meeting as mental health director. But
And it's just in our community, we hear it, right?
Yeah.
We have a loved one in crisis, they were in an ER, they were discharged. Loved one in crisis, they were in an ER, they didn't meet criteria, they were discharged. Why were they discharged? Where can they go? And so it just feels like we hear in the community, Safe Harbor is saying we're not seeing these. So
Yeah.
it feels like
Yeah,
and
so I
they're
think
seeing
there's-
opportunities.
Yeah, and I think there's opportunity, I mean, similar to our own challenges with billing commercial insurance, right? Folks who are getting discharged from the ER, they may or may not have Medi-Cal, right? I mean, if they have Medi-Cal, then we are the mental health plan, and so there should be some coordination happening with our agency to be assessing folks, and if they need stabilization for us to help, you know, make that happen. Because there's a Medi-Cal revenue component, billing component, you know, to that, but for folks who have commercial insurance, Safe Harbor would have to have contracts with those insurers, and so, you know, I think that creates some challenge for a small organization with very limited sort of internal infrastructure. We don't even have the ability to bill commercial insurance, we're a much larger entity, and so, but I think that's one of many things that on the Safe Harbor side can help for their sustainability, right? And then on the resource utilization side, can ensure that folks who need those services, who might have another insurance, can actually access those services. It's just
Well, and now it makes a little bit more sense about the concept of recommending 7 chairs, right? I mean, a lot of this is starting to make sense.
Yes.
And for me, as far as if you're looking at data.
Yes.
Right, so.
Yes,
it's all
yeah.
coming.
But when you're saying you have 6 beds that you pay for, if someone goes in. If someone goes in there and they're Medi-Cal, do you then bill Medi-Cal?
Yeah, so, yes, but for everything for Medi-Cal, there's a local match required, right? So we do have a local match that's required for some of this, but yeah, there is Medi-Cal revenue. So our contract is written, and I am not gonna remember the terms, accurately right now, but the way that we've written the contract for, crisis residential at Safe Harbor, we actually have the ability to place folks there, who have Medi-Cal, and we do have some capacity to send folks there and pay for their stays there if they don't have insurance or they, you know, and so that's at a full cost to us. It has to work out in terms of how many Medi-Cal folks we've sent, and, you know, so there's, we can't just have 4 or 6 people there who aren't insured, because we can't financially afford that. But we do have some flexibility there, so we did write it in a way, and we've always done that, where we have had some folks there, but there is a Medi-Cal revenue, there still is a significant cost to the county.
But aren't you paying, if there's an open bed?
We're
aren't you
paying
the
anyway,
full
that's
cost?
right. Yeah.
So the county saves money if those beds are permanently filled by Medi-Cal clients.
Yes.
Yes.
Yes, the best.
You say significant money. The other piece is that a recent change we made with the new iteration of this contract, we used to provide the medication support on site for Safe Harbor. So our psychiatrists would go out and do the medication support services because they did not have psychiatry, but they have taken that back on as their own scope of work. So they brought on a psychiatrist and they're doing on-site psychiatry. So that is another, they can bill for medication support services separate from the day rate for crisis residential. So that is another revenue opportunity for YCCC, actually. So which is and it's helpful that they're providing those services themselves. So we've been doing quite a lot of work.
Well, and just a quick add-on too, I mean, we talked a little bit big picture about the budget earlier, the general fund in the county's in free fall, we're in trouble. These, if we don't have Medi-Cal to bill, these are massive bills. I mean, we're in this at millions of dollars a year that we're spending, that frankly, we're taking from other places because we don't fund the mental health care system in YOLO. So, I mean, we're spending millions of dollars in places that are non-reimbursable to support children or adults for things like this when the insurance doesn't hit.
Quite often, we have people in the jail that may be in crisis that we're trying to figure out a placement where Safe Harbor could be a good place for them, but the bigger issue is what you do with them after the 30 days is up. Or will they stay? Sometimes they don't engage.
And 30 days isn't guaranteed, right? They have to continue to meet medical necessity in order to stay for up to 30 days, so, yeah.
That's what to do within 2 weeks. possibly.
Sure, yeah, absolutely.
Same
Yeah.
issues.
Yeah.
There's the afterwards, because a lot of money goes into stabilizing them. You know, they go into homelessness, go back to where they came from. they may destabilize and just start to come back, unfortunately. So it's a,
I think too, the question that was posed right around, do the hospitals know that there's this great resource out there and so on and so forth? And why is Safe Harbor habitually like underutilized,
Yeah.
right?
Yeah.
That, just what you just said, a lot of money goes into this, right? And so, you know, when we place clients there, when we place individuals there, we're footing the bill, right? And I think that, you know, for hospitals to place individuals at this facility, someone has to pay the bill, right? And I think that may be a piece of the puzzle here, right? Is that, you know, like Carlene is saying, that these are privately insured individuals or family members who are saying, my family member's in crisis, and I think they could have benefited from that. There may be a disconnect from how to get that individual into that kind of treatment and for the bill to actually be paid.
I think there's opportunity as well under definition. So there has to be something other than 5150. And if they don't meet that, we can discharge them because there's still unsafe discharges for people who do not meet 5150 criteria.
Oh, yeah, okay.
And so I think maybe there's opportunity for I don't know, for the county, or maybe to get people to come to the table to maybe make some, because then instead of them holding a bed in their hospital, in their ER, they would be more apt to pay for a stay at Safe Harbor.
Yeah, I don't know that, I mean, again, I'm not gonna say that I'm familiar enough with the funding mechanisms that happen this way, but I don't think the hospitals would be the ones that would pay when they discharge, they discharge,
Well,
right?
but they're responsible for a safe discharge.
I agree with that, there's no arguing that, I mean,
Yeah.
no one's over here
So
arguing that.
that's your only leverage, because
Right.
nobody has money.
I know that the hospitals know Safe Harbor exists. The problem is, or from my perspective, and what I've seen the problem, is that somebody comes into the ER and they're very agitated or whatever. They will do something, you know, they'll give them something, they'll try to calm them down. And then they'll try to assess them to figure out what the next step should be. This doesn't always happen between 9 and 5. It always happens, you know, at 3 o'clock in the morning on a Sunday or so. I mean, you know, a lot of this stuff takes place outside hours. So whoever's on staff at the emergency room may in fact not know about what that resource is. There is somebody at the hospital who knows. And maybe those are the people who, you know, who actually end up getting the placements in. But I think the reason people get discharged who are really seriously sick is because whoever the clinician they spoke to in the hospital wasn't necessarily aware that this might have been an option.
Yeah, I guess, sorry, and so my can of worms really isn't about, should they refer to Safe Harbor? And maybe this is for this other county committee where the ER physicians are, is what is the standard in this community for discharging somebody who's in crisis, who does not meet a 5150? Because my guess, it sounds like there's a wide discrepancy in what we consider acceptable. To your point, if I'm an ER doc, I'm not a psychiatrist, my one might vary from another. So is there a way to come up with some community standard with respect to, if they're in crisis, whatever this is, we do not discharge them? And then maybe there's ability for people to come to the table a little bit more to get in to these other programs without focusing on who pays for it. Because now there's this agreement that we can't discharge them. Because right now, if they don't meet 5150 criteria, it sounds like we can discharge them because it's not an acute care issue at that point. So that's really where I was going with this, is more like, is there a way to get people together to come to some community standard?
Something I wanted to kind of bring up to kind of address some points you brought up. So in terms of crisis, so I kind of know this on a kind of more consumer level. I'm also kind of like training to be a clinician myself. I'm in the middle of school for it, so I'm kind of like a weird hybrid between these things. But essentially from what I've seen, like functionally, there's such wide definitions of what crisis means among clinicians, among the general public, among healthcare providers, that it's kind of like, it's a catch-all term. And then the kind of like gray area in all this is where there's a lot of people slipping through the cracks. And like, there's a lot of talk about specific criteria for 5150s. Functionally, like as an EMS provider and functionally me myself, like what I've seen is like really it's up to the individual clinician to interpret what they mean as 5150 criteria. And functionally, sometimes people get let go that maybe should be on a hold. Sometimes people are on a hold that maybe should be let go. And I want to point out, like, using a hold for all levels of mental health care, it's just like physical health care, right? Using a hammer and everything is not appropriate.
And I'm not
You
saying
know,
that.
yeah, exactly. But essentially, that's also something I kind of wanted to point out is like there's a reason we have different levels of healthcare, and the thing is like there need to be more in between measures in terms of emergency mental health care, and hopefully Crisis Now is going to be part of that. The receiving center is going to be part of that.
Yes.
Safe Harbor is part of that. We're trying to like kind of
I
Tetris
get-
together all the things.
Totally, and I so
Yeah.
appreciate you making that point. I guess my concern is, I don't know that it's gonna function any better if we have such a discrepancy on what people are determining when I can discharge. So if they're not using a resource now, what makes us think they're gonna use Crisis Now any differently if we don't have some standard around criteria? That's it. I mean, I get it, and you're totally right. 5150 is not the end all be all, and certainly, but there are loved ones in our community, people that continue to fall through the cracks. And until we, I think, have a different conversation around it's 5150 or.
I think the discharge issue, and I totally hear everything you're saying, Martin, you're spot on. I think the problem is it's not a local issue that we can fix, right? It's a state legislative issue, sometimes a federal issue. And at the end of the day, it comes down to profits and money, and hospital systems are for profit. And so I hear what you're saying, I don't know how we fix that locally. I do think Crisis Now, at least when that family gets discharged and they're forlorn, they don't know what to do, they can drive down the street to Crisis Now and drop their family member off right away and get help right off the bat.
Yeah.
It's not great, right? But I hear you. But I mean, this is also something we could talk to state legislators about. And they're starting to refine this. You're seeing hospital systems do a little more.
Yeah.
But there's not a whole lot of local control ability or way to motivate the emergency rooms to really sync up or change these systems without some sort of state
Well,
intervention.
but and this will be last, I think we can't underestimate the number of ER physicians and how frustrated they are. And since we have a county group of ERs, I would love to just see, what are they saying? Are they open to getting a group together, some collaborative together to at least try to look at some standards?
Sure.
That's it, because really as a community, that's not your point. We can't fix all of this, but can as a community, we come together to say, because we don't want people, oh, they discharged me out of this hospital, so now the family gets in, they go and they drive to Dignity.
Sure.
Because they do that,
Yeah.
So if we could all, that's.
We gotta move on.
So last thing I wanted to bring up, so when I talk about kind of gaps in terms of like referral, I'm not just talking about the ER, I'm talking about psych facilities with Yolo County residents.
Yeah.
Out of county, so hospitals in Sacramento, hospitals in the Bay Area that have Yolo County residents and discharge.
And they don't know because they don't know what
Yes,
is available.
yeah, so then that's also a gap in terms of they could be referring to Safe Harbor, but they're not.
I'm so happy you're gonna become a clinician.
I'm ready, like, I'm gonna take on the system.
We need to move on, but I just want to make one final thought as I'm hearing this, and I don't know the inner machinations of Safe Harbor and everything, but like the model that we're using, where there's really no incentive for Safe Harbor to take someone in, because they're gonna get paid anyway. And let me just finish, and then you can tell me that I'm missing some information. Because there was once a situation, I can't remember exactly what it was, but Safe Harbor wasn't accepting someone for a purpose that I thought was strange. And I called Julie, and she said, that's not right. They should not be rejecting someone because of that reason, okay? And then they ended up accepting them. And my point is, like, it's easier for them, and I'm not saying they don't have good intentions, but it's easier for them if they don't have all these people there, but yet they're gonna get paid the same anyway, so the model doesn't seem to be a great model, and Carlene's gonna explain how I'm not understanding.
No, that's not necessarily. So if you will rewind the clock to my first local mental health board meeting and the most traumatic meeting, I'm just kidding. What people were very upset about was
And she, of course, looks at me like I was.
No,
Yes.
Nikki was not the only one.
there.
You're right, was passion. There was a lot of passion and loud voices, but what folks folks were upset about was that we no longer wanted to pay to hold beds, and we were gonna pay per bed, per day for utilization. And what we were told is, they will go under. Safe Harbor will go under if you do not hold beds, right? And so I said, and granted, this was a problem I didn't know existed until I walked into the meeting that night, so, or joined the Zoom that night. But, so what we agreed on was, okay, we will make no change, right, for this year, and we're gonna collect data. We're gonna look at the data, and then we're gonna use that data to drive our decision-making around contracting with Safe Harbor. So we did that, and we used that data to change the way we're contracting with them. So we are still paying to hold beds, fewer than we did before. And there is an incentive for them to take on more because of the payment structure that we've developed for every bed they fill beyond the beds that we're holding. Now, I still think there isn't a lot of incentive to fill those first 4 beds, right? If we're paying for them, I think it's 4 that we're paying for. And it is important for our system and for our team that we hold a certain number of beds so that we can guarantee that we can always place there. Now, we know those other beds aren't being used, but if for some reason another referral source started to use beds there, it is important to our system to make sure that we have guaranteed beds for our clients, right? And so I think we've tried to balance that. I have to pull up, and I'd be happy to send you the contract and you can look over the way that we've changed the payment structure, but we have made some adjustments to try to balance that. Do I think it's perfect? No. I do still think there is not a lot of incentive to take on more, although only 4 beds does not cover their cost of operations, right? And so, I in my heart believe that there is an incentive to fill more than 4 beds because they need that the revenue is important, right? For the operation, the full robust operations of the facility. And I think on our side of things, we are hopeful that when the receiving center opens, that we will see an increase in utilization of Safe Harbor because we will have those direct referrals and the direct transition going over. And we have been working with them to try to increase utilization. I have not seen data recently, so I can't speak to what the bed utilization has been, but that's certainly something we can get if we get it. And Tony can report that out at the next meeting.
I would just like to, and not take up too much more time, but just to add on to this, that it's not just that contract, right? We noticed over the past couple of years with some other contracts, like for example, that were funded by MHSA, right? Which would allow.
With Whitehall-C?
Huh?
With White.
Not with this particular, with contractors who shall remain nameless at this time, right? But basically, what it worked out to is like we have MHSA to fund or to support this program, and we can do Medi-Cal billing to draw in additional revenue. And essentially what was happening in some of these contracts is there was like kind of an incentive not to bill Medi-Cal, right? Because it would just be cost reimbursement, right? And so we were with some of these contracts, like what is the incentive? Like there's not a whole lot of incentive to provide some of these services or bill Medi-Cal or to do some of the other things. And it impacts the system, right? Because then we have less revenue to fund other projects. So I think that with many of the projects in our system, we've been taking a closer look at like what is the incentive to have some of these contractors do some of the things that we need them to do so we can draw in the kind of revenue that we need to, and we're using the money more efficiently, right? But to your point, yeah, I mean, if they're gonna get paid, if someone's gonna bail them out every couple of years, no matter what happens, right, it might not be a very good incentive for them to go out and like promote themselves.
I do think Carlene hit on, and this is the same in the homeless system of care too. We pay for beds whether they're used or not. A lot of times, good weather, they're not used at all, bad weather, they're overused, right? And so there is a balance for these providers to remain open and have a stable revenue base to project versus this fluctuation for a very hard industry. And so it's always a challenge, but this is sort of the industry standard when it comes to beds, whether they're shelter beds, they're mental health care beds, they're healthcare beds. Unfortunately, it's really tough to figure out how to kind of create that baseline contract.
So Tony, you gave me the perfect opening to sort of end with a phrase that I couldn't let Carlene leave without, I couldn't let Carlene leave without saying the phrase, what you're saying with those contractors, measurable results.
And we brought it.
You did.
Yeah.
That was awesome. What did you say?
That's why the kind of Margaret's the community standard, the implementation of SB 43, I think, opens up that discussion possibly also, because there's going to be changes with that on the 5150 hold instead of the referral process.
No, you're right.
All right. Okay, so
I had a question for the committee.
So they did all this great work, but I didn't really see an action or a closing of the loop on it. So what are we now doing with all this good information that is collected? And how are we gonna action it?
Is it? We can schedule another one.
Should we put that as an agenda item so we can have discussion?
Yeah,
about
let's do
what's
that.
next up?
Yeah, that's a good
Yeah.
thing.
Got that,
Because I know it's
Christina?
a nice job, nice job.
All right, what do we have on the 12th? Long range planning, we're kind of running up against.
And I actually have a document that I'm gonna send you, the review right now, so it's something you can review at the next meeting if you'd like, but I've kind of put it together for you.
Okay, so this is the
Yeah.
kind of just placeholder for today?
I think so, I mean, well,
Keep it on the
I think
radar.
Dee had brought up, like, and some others, like, what are we doing around some of our
Right.
long range planning? And so
Right.
part of it was that we needed to put it into a document for you, because there's two different places that some of the information was existing, so I'll send you a draft, it's something that you can build on.
Thanks.
Yeah.
Okay, public comment.
Jen Dancer, Namiolo County. I just wanted to go back around to Nithia's presentation and just thank her for coming and sharing that information tonight. I've been able to work with her for the last couple of years. I object to her graduating. She has really been wonderful in a leadership role with the NAMI on campus at UC Davis. NAMI on campus is a NAMI signature program, and we've been really pleased to partner with the UC Davis Club. So I just wanted to thank Nithya again for coming and sharing that and sing her praises a little bit, because she has really done a wonderful job in leadership with that club.
Okay, I'm just looking at our calendar. Any other public comments? I'm sorry. Okay.
I just wanted to thank all the board members. There are some new faces from the last time that I was here. And important work happens here, life-saving work happens here. And I thank you for being involved, for visiting, for gathering data. And I urge you, as new things roll out, please do a great job in PR and letting people know it exists. Because I had a wonderful experience when we had a center in West Sacramento. And I've lived in Yolo County since 2008. I have a loved one who has a mental health disorder. He has benefited greatly for almost every service that you've mentioned this evening. But one time in that many years, he had the opportunity to visit that center and get sent directly to Safe Harbor without a police car, without handcuffs, without a visit to the ER. I also had the very, very honored invitation from Karen Larson to be, at that time I was on the NAMI board, to be the NAMI representative to attend every single training session for Crisis Now. And in those meetings, when I saw how that system worked, I was in tears when I would leave, because I kept on thinking, if only it could happen all the time, like that one time that I took the drive, did the de-escalating myself, so there wouldn't be a 5150 when we got there, and had my son be able to go from West Sacramento back over to Woodland and be admitted to Safe Harbor. And I thought to myself, it should happen this way for all the people that are in that circumstance that you very kindly brought to the attention of the board, where there's such a huge discrepancy in that 5150 definition. And watching my son get discharged in Sacramento County when he didn't even know where he was supposed to get a taxi ride back to the homeless shelter in Woodland, but because it was on a street that had, I don't know, somewhere in Roseville, the same name, he ended up in Roseville. No idea where he was, didn't have a cell phone, stopped a guy on the street. So we have a lot of work to do in letting people know that those very, very high-quality programs are there. And every time I tried to go to Safe Harbor, it was full. So I don't know those days that it was empty. I feel bad because I could walk down this county and round up 6 people without any problem at all and fill it up. So be careful with how you gather the data and be careful with how you roll it out so that everybody knows it's there. Thank you.
Thank you, Donna. All right, any other public comments?
Does Christy have her hand up?
Yes, she does. Christy.
I think she was clapping.
Oh, clapping.
Oh, clapping.
Yeah, I'll keep it short and sweet. I really appreciate what Linda shared. And I mean, we have very similar experiences, being from West Sacramento. So yeah, that if only feeling is a motivator. And I just hope that, you know, as things come online, that this board will really work on the communication piece and the outreach piece and partner with the local communities to make sure that they're aware that these services exist. Thanks.
Thanks, Christy. All right. Okay, we ran a little late. I apologize. And thank you all for coming. And thank you, Nolan, and all of you for the pizza. Thank you, Carlene. I just want to say one more thing, just really quickly before we leave, Carlene. Like someone at your level, it's often the case where you're not really touching individuals, what you do. And I would say that when you've done this job, you've done it at the macro level, but also at the micro level where you've really made a difference with individuals, with us, those of us that have family members. So thank you again.
I have a daughter in crisis right now. Well, she's over in Sac County now. Our team is right now.
Oh, when this came back edited, somebody was so this is the edited version and it had to.
Yeah.
Which it removed, yeah. Okay, that's okay.
Thanks for everything.
Yeah,